Hey guys, it's Dr. Rosa. We're going to do another one of our short videos on leadership communications and EMS. So not specifically medical, but very important ancillary skills on how to communicate what's going on to other providers, how to ask for orders, and how to negotiate for things with patients or other providers. So this video is going to be going over the SBAR format for when we're calling in for orders or asking for something. And we'll go through this pretty quickly. It's going to refer to some of the other videos that we've done recently as well, the one on negotiation as well as the one on MIST. We've covered some similar stuff. So SBAR is a format for asking for things that actually comes out of the nursing literature and nursing practice as a best practice for communicating, generally when they're calling for orders from a physician or reporting a problem to a physician. And, you know, basically nurses have to deal with not just crazy people, but crazy doctors too. So they have a very reliable system for dealing with that to be able to get their communications through. And that really, I think, can help us in the setting when we're calling into the ED and talking to a doc who's, you know, got multiple things going on, maybe distracted, and maybe task saturated. And so the thing we want to do, though, is we want to make sure that the ER docs aren't, listening into our secrets here and figuring us out. So I was going to put this up. There's a sale over at Patagonia. You guys can go check out, maybe get a discount on some fleeces, and that should get them all off the video now. So we got some time to talk privately here. So as we're talking about, sometimes communications can be interrupted. They can be not heard correctly, or maybe not the top priority of the person receiving the phone call. And certainly when we're calling into a busy emergency department to talk to the doc, these are all possibilities. We can have comms failures for various reasons, distractions, etc. And so what SBAR does is it focuses on that situation, and rather than wishing that we had better focus and complete attention to the person we're talking to, it basically makes the communication style just basically redundant and reliable. And so SBAR is an acronym, and it stands for Situation, Background, Assessment, and Recommendation. And the idea here is that this is designed to be interrupted. It's designed so that if all that you're able to get to the person is the situation, that in that one situation line, you're able to really get them the key information that they might need to act on what you're looking for. And frequently, if you do this right, the person you're talking to may actually interrupt you after you say the situation and just agree to what your plan is, because it's just a very clear statement of what you need. So really, we're playing this to win. We're trying to keep this structured, and by having it structured, it keeps the communications concise and reliable and consistent. We're using the bottom line up front approach of just coming right out with what it is that we're looking for. We're assuming that there may be interruptions. We're assuming there may be distractions, and we want to give the person the answer that we're looking for from them so that they don't have to play 20 questions or try to read our minds. So if we start off with the first part of SBAR, it's situation. What is it you're calling about? And what do you need to say if this is the only thing that you can say? And you, at the very least, want to prep the mind of the person on the other end for what communication you're going to be giving them. So let's think of some different situations here where we might be calling in. So first one is for a pronouncement. You open up with, Doc, I'm calling for a pronouncement on a 75-year-old cardiac arrest. Now, if I'm in the middle of, 3 critical patients in the emergency department and running around, and I hear that from EMS crew that, from an agency that I know well and trust, I might stop you right there and just give you a time of death, because what else do I really need to know other than that you're calling for a pronouncement? Other issue is, let's say we have an agitated patient. Doc, I'm calling for an order for initial 5 milligrams droperidol IM for a dangerously agitated patient. And I can hear that patient sort of screaming in the background. Again, I might stop you there and say, go ahead, give 5 mg droperidol IM. Or, this is Medic 666 and we're 5 minutes out with a 65-year-old cardiac alert. Really, I don't need to know much else. I can get the rest of the information in 5 minutes when you get there. But if I've only got 5 minutes, I need to spin up resources inside the ED. So sometimes just the situation is all that you're going to need to get to. But, if you do get further, it's a way for us to add in more stuff. And the next thing that we're going to add in is the background, where we're going to add in a little bit more detail, but assuming that we might get interrupted before we move on to the rest of it. So if we go back to our pronouncement, we could say, this is an unwitnessed arrest with an initial revision of a VFib. It's degenerated into asystole after 30 minutes of CPR and 3 rounds of epi. Again, I might stop you there and say, sounds like you did all you could do. Time of death is 1945 hours or whatever it happens to be. Or for our agitated patient, we've given 10 of IM droperidol so far as adult male for hyperactive delirium with severe agitation, and he's still quite agitated and a severe risk to himself and providers on scene. Again, you're reinforcing that initial thing of what you're looking for and why. Or this is a 65-year-old gentleman, 30 minutes of sudden onset substernal chest pressure and ST elevation in 2-3 and AVF with reciprocal changes, and he has stable vital signs. Again, reinforcing this cardiac alert or STEMI alert, which is going to be the new nomenclature with the July update of the Denver Metro protocols. Now, if we get to the next step of SBAR, so our assessment, that's basically what you think is going on. And really, you want to lead the witness here. You want to reinforce this so that you're saying, I think it's this, so that the answer from the doc is, yeah, I think that's what's going on too. So again, assessment for our cardiac arrest. Seems further resuscitative efforts would be futile. It seems this guy needs additional sedation so we can safely assess and resuscitate him, which per protocol requires we call for an order. Or this looks like a clear-cut inferior STEMI meeting criteria for pre-hospital STEMI alert. Now I want you to notice the phrasing in this, and this is going to go to our negotiation video, which is another one in this series that we put out, where we're going to state this in a very passive way that is very objective and kind of disarms the ego. You'll see it seems, and this looks like. Right? So you're stating something and you're not saying I think or this is or something where you can potentially, maybe get into the ego of somebody who's got an overdeveloped ego where they maybe want to argue with you or debate with you about it. It also disarms your ego to use these phrases because maybe you aren't thinking about the big picture, or maybe there's something else that you're missing here. And by calling in for an order or calling in for advice, sometimes, phrasing it that way can actually set it up so that the person on the other end can be receptive and thoughtful about it. So it kind of cuts both ways, both in a good way. And then the last part of SBAR is the recommendation. This is where you circle back to what you said originally. What is it you want? Do you want an order? Do you want to deploy hospital resources because you're doing a STEMI alert, stroke alert, or a trauma alert? Or is it just advice? Hey, doc, I'm not sure what to do next. And be very clear on what it is that you're looking for. But if you are asking for resources or an order, you basically want to set up for that answer to be, okay, let's do that. So again, going back to our cardiac arrest, can you give me a time of death, doc? That's what you need. Maybe the doc isn't necessarily an EMS doc, or maybe doesn't understand what it is you're calling for. Or can I give the additional 5 mg of IM droperidol? Or we're 3 minutes out, coming in emergent, and then closing this with, do you have any questions? And this comes back to some of the other communication stuff we're talking about. So just to to reiterate that, we're used to being in a field where we talk on the radio and we have comms protocol and discipline and how we talk, and we use things like over, which means I'm done talking now and it's your turn to talk, or out, the conversation's over and we're both done talking now. Now, someone who you're talking to on the phone who works in emergency department or has never really worked in the field or learned radio, communications procedure, they're not going to know what these things mean. So I like to personally use this to kind of close out the conversation. And again, this is it tends to both disarm my ego and also disarm the ego of the person who I'm talking to. And the way I close stuff out is I say, have I forgotten anything? Or do you have any questions? And I'll put those together because, maybe there's something that they really want to hear that I haven't put in there. And they can say, yeah, actually, I do have a question. What was the vital signs? What was the blood sugar, et cetera, et cetera. But it's a very good way of closing this out, and it's a nice way of saying, I'm done talking now. It's your turn to ask me questions, and if you don't have any questions, they can basically say no. So again, it's humble, disarms ego on both sides, and then it sets us up for that answer of no, which we'll talk about in the negotiations video, which is another short video we put together, that people just like to say no. They like it better than yes, because it makes them feel like they're, just no has a feeling of authority and autonomy. And so, so again, I'll close out my communications with that when I'm, when I'm calling another physician as a consult, for example, or asking for things. I'll close out with that. So to summarize, we have communications are interrupted, not heard correctly, not top priority to the person receiving the call. So structuring how we talk to that person can basically accommodate that and mitigate the problems based on that situation. In the SBAR, we start off with situation, background, assessment, and recommendation. So if I've forgotten anything, or if you guys have any questions, please let me know. But otherwise, thank you for all you guys do. Keep up the hard work, and I hope you enjoyed this video and the other videos in this series, and we'll keep having some short videos that are easy and have some good tips you guys can incorporate in your practice. Thanks for all you do.